Welcome to the Beehive Doc Talks with Dr. Blair Rolnick. As a pediatrician and mother herself, Dr. Rolnick is here to answer your most pressing parenting questions and guide you through the tough spots.
All right, good morning, everybody. So we're here back in the office at Be Kind Pediatrics, and today we have a guest, Dr. Kassuto. He's joining us from down in Philadelphia. He's a peds ER doctor, double boarded in pediatrics and emergency medicine. And for anybody who knows him, I think they know he's a great mentor and the kind of clinician we all kind of aspire to be. He always puts patients first. And so I'm super excited to have him here on the show today.
Yeah, it's my pleasure, and I'm really glad to be here with you. And hello, everybody.
And today we're going to be talking about rashes. I've had a lot of questions recently, both through Instagram and other venues about rashes. So I thought it might be a good idea to cover a little bit about what's common, what's not so common, and everything in between.
Yeah, the story with rashes is, pediatricians become rash experts almost out of necessity. We see a lot of it. Both in the emergency as well as the primary care settings. My wife is also like you, a general pediatrician in practice, and she humbles me in terms of rashes or medical problems in general, because she jokingly or not so jokingly says, well, oh, you just tell them to follow up with your doctor, and then I need to, I with the family need to deal with the ongoing issues of the rash, and it didn't get better in one day and it's continuing and this sort of thing. So my life of rash management is often a lot easier than a general pediatrician's, because it's often a one encounter. And also we tend to be more academic, and sometimes you need real world solutions and not necessarily just, highfalutin academic solutions to a problem.
So funny that you mentioned that. I've definitely learned that firsthand. It's very easy, I think, to say, like, this is not an emergency, and follow up with your primary care doctor tomorrow. But then when they're actually in your office and you're trying to figure out how to best serve that family and child, it's a little bit more challenging because they tend to not just go right away, a lot of them.
And being a parent isn't easy, and you don't get a manual, and every kid is different, and all those kinds of factors make it kind of interesting on your side, especially. But you also have the advantage of the ongoing communication, getting to know a family, seeing something as it develops, and rashes in particular. Part of the figuring them out is what happens over time.
Right, which leads me to something I actually learned from you, which is I always tell parents, so this is one tip I think for the parents out there. As soon as your kid gets a rash or you start to notice something funny on their skin, take a picture of it, and then take a picture of it kind of every day if you can. And that information is really helpful, I think, to clinicians to see how it evolved, where it started, what did it look like, because they do change a lot. And then when you're a busy parent and you're exhausted, especially if it's a younger child, sometimes you don't remember all those little details that are, quite helpful. And a picture, says 1,000 words. So that's something I definitely picked up from you. I'm always like, take a picture of it, take a picture of when it starts, document it every day.
Yeah, rashes are it's kind of like your skin is doing storytelling, and sometimes you have to know where the story started and then where did it go and what happened and what was done for it, what was done to it. For it could be what the family tried, what a doctor tried. To it could be the kid kind of, scratching and all that sort of thing. And then it changes. And we have rash sometimes we call it incognito. It's like the rash, but it's not quite the way it's supposed to look when you look it up in the book, because all these things happened along the way. And that's kind of where the tale takes you. And visual helps. It helps a lot. It's kind of a visual diagnosis kind of thing for the most part. The other kinds of tips is take good pictures and take many pictures, because, where on the body is it? When I say good pictures, a lot of it speaks to light, because rashes involves looking at color. And if you're in a dark room or with some sort of artificial lighting in the camera, depending on your phone and how good the camera is, you might get better or worse images. But a lot of times natural light, but not like really bright, but just enough natural light to kind of give it so that you have a sense of what the color is. And also the color of the person's skin affects how something looks. And, darker skin rashes look what we call, red rashes on dark skin. Well, it's reddish, right? It's
Right.
not necessarily red as opposed to paper white skin where it's okay, that's red.
Right.
So a lot of those things kind of factor in.
Yes, that's another great point that you bring up. I mean, I've seen, mostly from learning from you, how different a rash can look if you have the incorrect lighting. So sometimes a rash on a phone looks much more scary sometimes even than it does really in person. So definitely either if you can't get some natural light on it, a little bit of a flashlight sometimes helps. Turn the flash on your phone. And then you always tell me, do you think the picture looks better if it's zoomed in by the parent or zoomed out and then you can zoom in?
All right, so more rash photography tutorial stuff. So in general, this is true in photography in general, it's often better if you're looking for depth to have your light coming in from the side. So like using the phone's flash, which is kind of I don't want to say bad things about any particular manufacturer of phones, but it usually puts the light like flat.
Right.
And rashes, one of our questions with them is, what's the contour? Does it have depth? Is it scaly? Is it raised? Is it flat? And if you're taking a picture of it and using a camera flash, it flattens it. Even if it's raised, you may not be able to tell. So you light coming in a little bit from the side. So sometimes you can put on the flashlight of a second phone and bring it in from the side, or like you said, with a flashlight, not too bright though, because then it tends to wash out all the colors and everything. You can do that, and then how zoomed in. And from my perspective, more is more, because this is true with kid photography in general. If you're not using the motor drive, rapid sequence, taking pictures of your kids, you're going to miss and catch things. And this is true for kid photography. The kids, leave me alone. I don't want to be taking a picture and what. So you just shoot a bunch of them and try with the light on this side, try with the light on that side. Get in close. Either with the camera, some of the cameras have macro, but if you get too close, you're blocking the light. And then the other thing is you could also use the zoom, but try to use the optical zoom and not the digital zoom. Now we're getting into tech stuff. So some cameras you can zoom in, but it's not the lens of the camera. It's all artificial software working in the background, trying to get in closer, and it reduces the quality of the shot, the resolution of the shot. But if you're using the lens, like on an iPhone, for example, you have like 2 or 3, depending on 4 buttons on the bottom with the lenses, like a 0.5, a 1, a 2, and a 3 on the newer phones. And those are actually the lenses on the camera or some variation of the lens. If you go between those settings, you're getting a less excellent quality image. And that's true in general, not just for skin photography. But yeah, pictures and videos. If your kid's doing something weird, some things in life happen intermittently, in medicine especially. And if if you come in and try to, or they make a weird sound, they're coughing and the cough sounds kind of weird and it's kind of, sometimes that changes. And you come into the doctor's office, into the emergency room, you say, oh my gosh, she was struggling to breathe, or she was, making all these strange sounds. And you say, can you imitate it? Did it sound like this? And, a 5-second video clip says he was doing this or she was doing that.
Yeah, it's a very
So it's a
powerful
power
tool.
tool. It's a very powerful tool for a parent, and it helps us. Boy, it speeds things up. It answers questions right away sometimes.
Yeah, so in my world now, if you actually have a picture of the rash, I can submit that picture to a pediatric dermatologist for virtual e-consults. And this is one place in medicine where I think virtual e-consults are really great, because you don't necessarily need a full exam for a pediatric rash. You need a really good history and lots of great pictures. And so having those pictures comes in particularly handy for me when it's a rash that is unique or challenging, or that might benefit from an expert opinion. So definitely take pictures. take pictures of not just rashes, but anything strange that's going on with your child, take videos, and bring them over to your doctor so we can take a look at them. Because the other problem I find when I'm trying to kind of remake, especially sounds, is I think I sometimes can lead parents because they're like, oh yeah, it did kind of sound like that, but I'm not sure, did it really sound like that? Or I'm leading you into a diagnosis potentially. So definitely the videos are more helpful than us trying to kind of go backwards and figure out what the sound sounds like or what the rash looked like potentially.
Yeah, it's leading the witness,
Or the witness, yeah.
leading the witness with making suggestions.
The one that, and this is kind of off topic, but the one that I'm always worried about that with is croup, because the barky cough has a huge kind of bandwidth of sounds, and so
Yeah, I've over the years I've tried to fine tune my imitations. So often what a parent calls wheezing is not necessarily what we call wheezing, right? And the quality of a cough, there's a large range. And back to croup, croup is very distinct, but even in croup there's a range.
Right.
It could be high pitched or low pitched depending on the size of the child, and onwards and upwards.
Right. Definitely. I mean, I think that, again, just one benefit of the emergency room is you see it in mass often, and so you get a much broader range of exposure to those sounds, which is great. But just to circle back, so you were kind of talking about something in the beginning about how difficult it is to be a parent and how it's very scary and challenging. One of the areas I always universally try to tell parents about ahead of time is newborn rashes, because they look really scary, and you have this new baby that didn't come with a manual, like you so eloquently said, and a lot of them do get newborn rashes, and they are usually like diffuse and over the whole body. And I find a lot of the time, if I haven't had a chance to talk to those parents before baby came, I'm always getting a call around 1 o'clock in the morning. It always seems like that they broke out in a whole body rash that looks horrible, and what should I do? So I just want to take a moment to kind of discuss what those rashes look like, because they're very typical. And they usually look like either little white bumps all over your child's body. Those are called milia. Or sometimes they break out in a diffuse, and it has a very scary name, erythema toxicum, where they have red blotches and bumps all over their body. But if the baby's otherwise acting well, they had an uncomplicated delivery, they don't have a fever, they're eating normally, they're not super irritable, and they look great, it's usually not something that you have to worry about, and it'll go away on its own in a couple of days to weeks.
Yeah, what you just said is probably the key in my algorithm of thinking about rashes in general. And the first question in my algorithm in my head is it rash and well or rash and sick? And that's probably half of pediatrics. I jokingly say that's why they get a third year of residency in pediatrics, is to really nail that thing in general, not just with rashes, of recognizing a child who's truly sick. And when we say sick, it's different. Emergency medicine sick,
Right,
not a parent, very worried about a child with a fever. That's sick, but not, I guess, sick exclamation point. With a bold, cap lock, underline. Too many font changes there, but it's really, that's what we mean by sick. And
yeah, I always have to tell parents, when I say sick, just so you know, because I came out of the emergency medicine world a little bit, I always say to them, when I mean sick, just so you're, not scared, I mean so sick that they have to be in the hospital. And that's what really sick sometimes means to me. And I just have to catch myself every once in a while, because I know, as a parent and as a general pediatrician now, that not everybody who's sick needs to be in the hospital, but they're still sick.
Right. And then there's sick on a spectrum, right? He's not eating the way he usually eats, but it's still eating great and still drinking, but I'm worried that he may be sick. All the way to he's really not eating anything, not drinking anything, for extended amount of time, and not peeing and not making tears and okay, you've convinced me, the child, And so these, when they hit, and there's a gray zone in the middle, which is really tough, right? So things in general, it's easy. Things are easy in medicine on the extremes, because you know what to do. right? If it's really, really mild, you kind of know what to do, and or you do know what to do. And if it's really, really bad, we usually know, as long as we can recognize it, we know what to do. But all that stuff in the middle, and there's the book, and then there's everything else that's not in the book, and or variations on the theme, like we said, incognito, or we're taught if you have multiple things going on, try to tie them together with one diagnosis. But you know what? Sometimes there's two diagnoses going on, or even three, and it's like, what's this? What's going on here? It doesn't make sense. I can't tie it together. Or one thing leading to the second, which leads to the third, and back to that's why you'd like to see the progression of the rash and see if the story helps you figure out what's going on.
Yeah, I agree. Definitely when you think about a rash, and on the parent side, you want to know, and I think parents do a pretty good job. They've got a pretty good, I guess, in medicine we call it gestalt, but parents also have a little bit of gestalt. They know, I find I always ask, are you a little worried? Are you very worried? Are you really concerned? Are you medium concerned? Because it also helps me gauge how, especially when they say my child's been either not eating a lot or acting funny. I'm like, well, how concerned are you about this? Are you very concerned that they've been acting funny? Or you're just like, oh, they've been tired and sleeping kind of off. And they say, no, I'm only kind of a little bit concerned. They haven't really slept that much. They've been a little cranky. And I think that also helps, but particularly in the setting of rashes. And there's one, I was talking to, before the episode about this, there's kind of in medicine, or at least in the beginning of your career, there's rashes that people classify as always they should be a red flag. And that is a rash on the hands and palms, except the most common exception is not a very concerning rash that occurs on the hands and palms. So I just wanted to talk a little bit about that one, because I think a lot of parents are very concerned, especially parents who are either in the healthcare field or they have family in the healthcare field, when they have a kid with a rash on the hands and palms.
So when we try to figure out rashes can be, it takes a while to learn, because there's, people have seen all kinds of, even lay people, not just medical people, probably seen all kinds of rashes in their life. And that's just what you've seen. There's a lot out there. And when you open up a book of dermatology, the study of skin in medicine, it's like, whoa, all these chapters and all these different kinds of rashes and all the, variations on them. And one of the tricks we use is to try to find something very particular or distinct about the rash that often can help serve as a clue. It could be the color of the rash. It could be the location of the rash. It could be the path that the rash took in terms of developing. It could be changes it made over time, or very unique appearances. And as we teach it, we try to plant these scripts in all our heads. If you hear these three, one of the tricks in dermatology is describe the rash. And if you hear yourself saying certain words, it's like, okay, that's taking me either to the diagnosis or pretty close. Right. So you try to narrow the field down. And one of the clues we have, not all rashes go to palms and soles. And once you get a rash to palms and soles, you just took that whole textbook of pediatric dermatology and narrowed it down maybe to a chapter.
Right.
And then you get into what rashes. So when we look at these things, we do it's real intelligence as opposed to artificial intelligence, an analysis in our head. And we have we use something called a differential diagnosis. It's like, what can this thing be? And there's the comprehensive differential. Well, there's 30 things that this thing could be. Well, that doesn't really help me. At least I should consider them, because if I don't think about them, I'm not going to name that thing. It has to be on my list. It's to some level in my consciousness. But then you say, okay, well, there's other different ways to look at a differential. And one of them is, what are the common causes of? Well, guess what? That list just got a lot shorter. And you could even rank it in terms of what's common and what's uncommon. And then you could say, this now entering, my world in emergency medicine, what are those in this list that that could really hurt somebody, and I've got to do something about it now or very, very soon. And so you're kind of alluding to those too. So if you see a rash in a location, is there another rash anywhere else? Is there a rash on the outside? Is there a rash in the inside, in the eyes, in the mouth? Is it, is the child back to the top of my algorithm? Well and,
Yeah.
rash and well or rash and sick. And what does the rash look like? And palms and soles already narrows you. So probably the most common palm and sole rash, which is usually a dotty rash, like small dots. Sometimes it has what we call a vesicular appearance. What that means is it's kind of maybe like a tiny little bubble. It does that sometimes, not as much as dots or either flat and raised dots. And on the palm, sometimes it kind of gets that little bubbly appearance, but doesn't rise up on the palm. And so it has variations on the theme. And the other distinguishing feature is it's not just on the outside of the skin, it's on the inside of the skin. And it particularly likes to go into the mouth, the gums, the tongue, the roof of the mouth, the throat, and it causes a inside rash. We call it an enanthem, so a rash on the inside. And that's a huge clue. And so putting all that constellation together, often associated with a fever, so that kind of takes us into the sick, not the sick exclamation point, sick, mild to medium, and it takes us into that world of having a fever. And sometimes it's an enterovirus usually, so sometimes they have a little bit of touch of the diarrhea with it. Maybe the fever's not high, and another thing, sometimes the fever can last a little long with this. But putting all that together and then thinking about those oh my gosh rashes and looking for features of those, and at least keeping all the other rashes that can do this palm and sole thing in somewhere in your mind, saying, are there any? We talk about red flags. Is there, so it fits the picture. But hey, wait a second. There's this little thing. Says somebody sitting there with a flag saying, look at me, look at me. And you have to, that look at me could be the parent. You were talking about listening to the parent. And that's also one of the tenets of pediatric residency. We're all taught, listen to the parent. There's often something in that concern or something in that story where if you listen carefully, just like listening for a murmur, listen to what the tale they're telling, it might be in there that takes you to the place where you figure things out. And it may not be the common thing, but guess what? What's common is common. And
Right.
yeah, and so we do a delicate dance. We talk about reassuring parents, but we're always kind of we're doing two things. We're reassuring on the one hand and saying, look, this looks like hand, foot, and mouth disease, right? That's the diagnosis that we're talking about. But, you got to keep an eye out for these things. And most of the
Right.
kids who get this, with these tricks that I'm going to teach you, hopefully you should get them through it most of the time. But sometimes either the tricks don't work and it's still bread and butter hand, foot, and mouth disease. And, but they need a little more help more than you can do at home. Or there was a little red flag there that was saying, maybe it's something else going on. And that's not common, but it does happen. And as doctors, we kind of have to put some of that on the table. But then you've got the anxiety that it provokes at a parent. And so you've got this balance of kind of reassuring on the one hand, and yet warning and just saying, hey, you need to keep an eye out for this, but that shouldn't make you go crazy or be too nervous, or depending on the personality of the parent. And back to no manual and no, parent says, I didn't go to medical school. How am I supposed to know? And so it's a delicate dance.
Yeah, I always tell parents, you will know if something is really wrong or you're really concerned. And if you're wrong, no big deal. You called me, we brought him in, I saw him, and everything was fine, and that's great. But if you are concerned, just reach out, because the worst you could do is have a sick visit that you didn't need. But I find that most of the time, parents are pretty good at not calling me if there's really nothing going on, because I just think that speaks to the fact that you really know deep down if something is wrong. or if something's kind of odd or off or behaviorally changes, parents are very good at picking up on them. But the other kind of interesting thing I think about hand, foot, and mouth, just because we're talking about it, and I've had a few cases of this recently, which is they don't come in with their parents don't notice the rash, maybe. So maybe the child has come in and they're just not eating and having a fever. And then I'm like taking off the diaper and, putting a microscope to their hand and feet. And they're like, what are you doing? And I'm like, look, there's a little rash here between this finger and on this toe and right here in the diaper line. And then you open your mouth and you're like, wow. The parent's like, I didn't even notice that. And so that's also kind of an interesting way that it presents, because sometimes the rash is so fine or there's just a few of them that you don't notice. But it's just a good thing to kind of keep in mind when your child is maybe not eating and has a fever for some reason. Check the inside of their mouth, check their hands and palms and soles. And the other place that likes to go is the diaper.
Right. So we jokingly, and it's actually probably accurately call it hand, foot, mouth, and butt disease.
Right.
Because it does like to go to the diaper area as well. And it sometimes goes outside of the hand, foot, and mouth, but that's where the rash is concentrated. You might see it in other places, and it does like the mouth. Sometimes it's just in the back and throat. Sometimes it's in the front. Sometimes just a few, like 2 sores in the mouth.
Right.
You're talking about kind of the subtle findings. The old-time pediatric dermatologists used to carry around a giant magnifying glass. They just sit there like looking at the rashes and at the kids and stuff like that, looking for very subtle stuff. Nowadays I use my phone for that too, because your phone you can magnify and see things. And sometimes, back to the technology, you could freeze it in a moment. Hell, you could zoom in now. Yeah, you used to need a magnifying glass for that, and now you can just go zip, zip, and you get to really look at it very, very closely without putting your face on it. So it's another power tool. But yeah, sometimes they can be atypical, both in the very mild as well as in the very severe. So sometimes they get it really bad and they're covered, and it's the rash is some of the variations on this are in kids who have an underlying skin condition and then get hand, foot, and mouth on top of it, talking about 2 conditions. And so because their skin is, scratched up, broken down, irritated to begin with, and then you throw hand, foot, and mouth on it, their cases sometimes tend to be more severe. And the rash tends to be more intense, and they sometimes get sicker from it.
Just because you were breaking up, sometimes they present atypically. I guess it made me think of, what are some of the rashes that you feel like you frequently see in the emergency room, but aren't necessarily emergencies, but they look quite bad, and so it maybe made the family come in, even though it wasn't something as terrible as it looks like.
Well, your kickoff with the newborn rash is kind of a classic for parental concern. So often it's a new parent, certainly a new parent for this child, mm-hmm. right? Even if you have 4, the number 5, right. It might do things that 1 through 4 didn't do, and right. You kind of have an expectation that a baby should have just regular skin. It shouldn't have bumps, and it shouldn't have marks, and it shouldn't have, and so parents see these things and they are potentially scary. It's like, what is this? And some of them are even things that come and go, or something that comes and stays, or something that stays and gets worse and then gets better. And most of them, almost all of them, as long as the child is otherwise well, besides the skin, usually it's not what we call a true emergency. It may be a problem, it may be a nuisance, it may be a huge nuisance, depending on the rash and if it's itchy or something like that. But for the most part, it doesn't hurt your child, but it may make you, as a parent, you don't want your kid having this rash. Never mind how it might make you feel, the baby feel, or how it looks and things like that. But many of the newborn rashes, like you were mentioning earlier, there's one, probably it's one of the more common ones. It's a horrible name, right? Erythema toxicum neonatorum. All right, so break the words down. So erythema is red, neonatorum is newborn, and toxicum, it's like the kid is toxic. And when we use the word toxic, that's one of our sick words.
Right.
in the medical field when we're describing, and these kids are not sick. I don't know where the name came from. So I think they've kind of advocated to change it to erythema neonatorum.
Victorum?
Some people say erythema neonatorum toxicum, and it's like, no, not. You should, in
No.
parentheses, right? Erythema neonatorum toxicum, not, as in they're not toxic. It is red, and it is, and it's like a it's a rash. They get red marks. It can go all over the place, and sometimes they have a little raised in the center, maybe with a little bit of a yellowish hue on it, and it's transient. It's in the earlier part of the newborn period. Um, no one's quite sure why some kids get it, and above all, do no harm in what we do in terms of therapy. There's times when a parent is begging, do something, and the answer is the treatment for this is do no harm. Don't do something that's gonna, potentially hurt the child. It's hard because we're in a culture of do. There's an expectation culturally, fix this. And there are things that, yeah, they'll get better, but we don't want you, doing something that could hurt the kid or just not be beneficial. So why take any risk if for certain things? So that would be one of those usually.
Right. And this is usually the time where I always tell parents, or at least parents of newborns, don't put cortisone on your child unless you speak to your pediatrician, especially a newborn, because it seems so mild. It's over the counter. We put it as adults anytime. Some adults, every time they get a bite, scratch, or itch, slap a little cortisone on there and it seems to go away. But this period of time is one time you really want to not use cortisone on a newborn skin unless, in children in general, really unless you've spoken to your doctor about it first, because it can cause, long-term damage to your kid's skin. So this is kind of falls into that category of don't do any harm.
Right. And that over the counter is a scary place to go with kids. It used to be even scarier. Uh, but think about it. There's baby aspirin out there,
Right.
right? If your babies are not supposed, that in the old days, when I was a baby, they gave me baby aspirin. We don't do that anymore. It's associated with potential for harm in multiple ways. It's kind of amazing that aspirin's over the counter in terms of a medication, but it's an old med and it got in as an over the counter, and there it is. You can overdo it with many of these, and there are times when you would, especially in babies, especially in the first year of life, if you yeah, cold medicines is the big story.
Yeah, so you can say while we're on it, there are just a few maybe you should mention. Cold medicines is definitely one. And topical lidocaine also, I think it's pretty amazing. 4% topical lidocaine over the counter can be quite harmful in pediatric patients.
Right. So the story with skin medications in especially young children, their body surface area relative to their weight is very large. So there's a lot of skin relative to how much they weigh. And skin absorbs stuff. People probably know about all these patches you can use as medications and stuff. So those things are formulated for skin absorption. But even things that are not necessarily formulated for skin absorption can be absorbed through the skin. And coming back to babies who are kind of more sensitive and their skin's a little different and there's more of it relative to their size, steroids is one example. They can absorb steroids, lidocaine, especially the higher concentrations, especially if it's something that's meant to be put on the skin. There's some of the topical, in the old days, I don't know if the newer ones have this, the anti-itch creams, they have Benadryl in it. I don't know if there are many more left on the market, but
Oh,
if you
there's a
put on
ton.
enough on a large enough area of skin, especially if the skin is broken. When we say broken, we don't mean there's anything like it's
Cracked.
you
As
need to
kind of the classic,
disrupted
eczema
skin,
is disrupted.
areas that have been itched and where stuff can get in more easily. Any of these medications, and you can keep running with the list. I'm trying to think what else.
There's topical NSAIDs now, so those have pretty good absorption.
And I think probably in the world, we will come to a point because transdermal dermal across the skin medications is kind of brilliant if you think about it, right? Because especially for children, if we were to develop stuff where it would be studied in kids and dosing that we know what it is, but wow, imagine you could do a Tylenol patch, and but again, these things don't exist, especially for infants, and haven't been studied, and the skin story is different for young babies. So we're pretty cautious with applying things to the skin, and probably anything besides the moisturizer. Yeah, I would say, that's a medicine. You should probably be talking to a healthcare professional,
Definitely. I agree.
especially in the first few months of life, and probably for the first year.
And I guess kind of as we were talking, it just reminded me again, one of the great, or one of the rashes I find just kind of does that incognito anything. And sometimes it's really hard to get parents on board with the diagnosis because it doesn't look like it usually does, is eczema, because it can present in such a wide range of ways. So is there any kind of like presentation of eczema that you've seen that looks really strange and you're just like, wow, but this is this exact type of eczema? I just think that they're really interesting.
Right. Well, there's nummular eczema, which is one of the classic variations. So typical eczema is sometimes it starts with the family story and then it gets down to the patient. So there's a group of illnesses that we talk atopic disease. It's not really a disease, but it's a group of conditions that people can get that tend to run together genetically, and run in families. The poster child is asthma. And then with that, also associated is things like seasonal allergies, and then eczema falls into that group of illnesses. So if you have a family history of any of those conditions in other people and a rash in a child, it enters more strongly into the possibilities. Or if that child had any one of those other kind of conditions, of these allergic related conditions, then it raises it. So they have asthma and now they've got this rash. Well, yeah, we know eczema is more likely in this child because of this thing. So yeah. So variations on the eczema pattern. The classic eczema likes to go in skin folds. It particularly likes not the elbow side of the elbow, but the bending part of the elbow. It likes to go behind the knees. It likes skin folds in other parts of the body, and then sometimes other places. Sometimes it likes the cheeks.
Yeah.
Yeah, it likes cheeks sometimes, and sometimes even diaper rashes, which is a whole. No, we can go there too if you want to. There's different kinds of diaper rashes, and eczema's on that list of diaper rash stuff. But then it's got a classic appearance. It's a what we call an epidermal rash. What's epidermal mean? So there's layers of the skin. There's a very top layer, and then you go deeper and deeper and deeper. And the epidermal layer is the very surface of the skin, and the hallmark of eczema is that it's a scaly rash. But that's when it does what it does naturally. But if you put moisturizer on it, or you put a steroid cream on it, and or other things, it starts looking not quite as scaly. And also, many rashes can cause changes after they leave. And sometimes in kids, especially with bad eczema, we can see those changes, and it kind of tells us there was a rash here. Most commonly, the skin doesn't come back quite the same color as it was before. And It could be either too dark or too light. And again, where that too light, too dark is sometimes helps tell the story. And so, but variations on eczema, it can sometimes be not in the classic places, and it can kind of be dotty, or in small patches, scattered around. And yeah, again, back to these dry, scaly patches. But there's other, it starts getting confusing because there are other rashes that do these kinds of patches here and there. Another variation is sometimes it likes to go to the fingers, or the toes, just there, and it's causing scaling there. And so we have this crazy, so some of these names are blasts from the past and they kind of stuck. It's called dyshydrotic eczema, where I guess it means your fingers don't like water. but it's not necessarily from water. It could be also if you're wearing gloves, certain kinds of latex gloves, or chemical exposures. We see it in toes in kids. That's a very common mistake that sometimes adult doctors make. They see something that kind of looks like a fungal toe
Right.
infection of the skin on the toes, and little kids, it doesn't they don't they get fungal infections, but usually not there, not on the toes. And oftentimes it turns out to be dyshydrotic eczema. It's eczema of the feet or the toes.
And the nummular eczema, I see often sometimes the parents, not often, but a few times I had parents put on over the counter Lomotrin because they think it's ringworm all over. And then they're freaked out because they're like, there's ringworm all over my child's body. And I've been putting Lomotrin on it and it hasn't gotten better. And it's actually nummular eczema and not, you know, a widespread outbreak of ringworm.
So the round rashes, so we talked about palms and soles earlier. That's another kind of clue to rashes. It narrows you down once you start getting round things or round-ish things here and there. And then you say, okay, what does round? And then round what color, round what size, round where on the body, round
Right.
and any associated symptoms. But all those things are important clues that kind of take you, because it takes you away from a lot of other things that aren't round. And it
Yeah,
narrows it down
round
a
is
lot.
kind of unusual. So it does help narrow it down. And I guess since we were talking about unusual, or there are some rashes for me that I'm like, I always want to at least I want to see that child, lay my eyes on them, or I want to know about it. So what kind of rashes fall into that category for you?
All right. So rashes that can be emergencies, I
Or
suppose,
at
is
least
the
that you should, yeah, I think, warrant a call. Let your pediatrician, your primary care doctor, whoever know about. Because I think a lot of the times, experienced parents, their kids get a rash, they don't do anything about it. It kind of goes away on its own, or they kind of know what it is. Maybe they've had a few children with eczema. They know this is eczema. They kind of just put in their eczema plan that they've already had for previous children. But there are a few rashes that I'm like, every single time I want you to at least let me know about it.
the first is rash and sick. Um, it would probably, and again, back to not little sick, medium to worse sick. And it's, that would be one. So, for example, with hand, foot, and mouth disease, often because of the sores in the mouth, it hurts to drink.
Right.
So that's also, and they have fever. So now we have a kid who's got this rash. The parent may or may not have noticed the sores in the mouth, and they really won't take anything. They don't want to drink, and they have a fever. So that's kind of rash and sick. That would be an example.
Right. So not eating, not drinking, not making the same
Not
amount of urine.
drinking, either the two extremes of behavior that we talk about, so irritability, and not just the kids cranky and crying and, just being like
But
trying to get
truly kind of
attention.
inconsolable, can't calm them
Right.
down.
What we in medicine call irritability is on the extreme of the scale. It's
Right.
not the kid's just angry at me now. That's
Right.
not what we call irritability. And same for lethargic. I may not feel so great today and I'm feeling lethargic at work, but hey, if I'm working, I'm not really what we would call medically lethargic.
Right.
If I'm able to do that, that means like bleh, just really out of it and not doing stuff. And so that would be the first red flag for make contact with the medical person. And then there's certain particular rashes that are that worry us, and they may be something bad, but maybe not. And so one of them is what we call the not. It's a group of, it sounds horrible, the name hemorrhagic rashes. Hemorrhagic means bleeding rashes, but bleeding rashes could be you bumped your knee against a table, and you could say that's a hemorrhagic rash, right? Because you got a bruise under the skin. So if you've got a rash that is non-blanching, what does non-blanching mean? It means most rashes, many rashes, if you like, especially the ones that are kind of reddish and such, if you take your finger and just press on the skin and release real quickly, And you can actually see it here. My hand, my
Yeah.
finger blanches, just my skin blanches when I let go. I don't know how, in terms of the fidelity. Never mind if you have a rash there. But some of the red rashes, you press on them, you let go, and immediately the rash isn't there for a second, then it kind of comes back. That would be a blanching rash. Some of these rashes, you press on them and nothing changes. It is the same exact color, the same size, the same shape. It didn't change at all. And they could be like a bruise. If you notice, if you ever get a real bruise, not a like a little bit of irritation or something like that, but like you whack that thing hard, whatever part of your body, the bruise is not going anywhere. You look, it's you press on it and you let go, and it's still the same purple color. And so that would be a non-blanching rash. And sometimes those can be very serious. Those would be a touch-based thing. But on the other hand, sometimes you get those and it's not really a concern. So, for
Right.
example, one of the types of these non-blanching rashes are little dotty pins, pinpoint. They're like tiny, tiny little dots, and we have a special name for them. They're called petechiae. They can happen for all kinds of reasons. Probably a really, 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 really common cause is when a person does vomiting. It's Valsalva. It's anything where you're so, anything causes you to strain, even
Right.
momentarily, really hard. For example, you see this in the delivery room after women deliver babies, just from pushing so hard. They pop
Right.
little blood vessels on the skin, on the face, especially around the eyes. But children as well, even bad constipation. The kid's sitting there straining real hard. Guess what? You might pop a couple of little blood vessels over here, and bad cough, and even a single vomit. If they're really retching, like hard, 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 you'd be surprised if you look hard after your kids either had a good barf or a really hard cough once in a while. And it may not be right immediately, and it really likes going around the eyes and kind of over
Hmm.
here. And you see teeny, teeny, teeny little dots around the eyes. And depending on how bad or how long they've been doing it, it could spread in kind of on the very top of the body. So, anywhere on the face, and then some people allow it as saying, hey, it's okay, down to the collarbone. Some people take it down as low as the nipples, but it does not go anywhere outside of the box of,
The top of the
kind of
bus.
above the shoulders ish. And if you're seeing these same dots anywhere else, that's a call at the very least. Even if the kid looks well, it's a touch base.
Right. I kind of put that blanket statement out there about things that don't blanch because if it's something that simple, usually I can figure it out and say, hey, don't worry about it, but look for them elsewhere. But at least let me know that it happens. So I know, it's on my radar and to look out for it. And the other one I always think about, I kind of always want to know, it might be different for me than for you, but vesicular rashes. So you talked a little bit about that in the beginning, and they're not always harmful, but it's one of those rashes where I'd rather know about it than not know about it. And a vesicular rash really means kind of like a fluid drop filled little, it almost looks like a tiny little blister, but they are spread out more. And especially in those young babies, I want to know about them. Even if you see one or two, I'd rather know than not know, because
Right.
they're kind of in that family where it could be something bad and it could not be, but I'd rather know and help make that decision with you.
When we see vesicles, there's a range of conditions that can do it, from the really not concerning to the very concerning. And sometimes even the very concerning depends on the patient. So it could be, if it's an adolescent, it's a concern, but it may not need to run to an emergency department. Maybe it's something you can deal with your pediatrician. But certain of these rashes, especially in infants, children under a year of age, and the younger you go in that age range, the more these kinds of rashes are of concern. And vesicles would be one of those. And again, it just might be a reaction to an insect bite. Without any, and again, even insect bites. Sometimes if it's rash and well, as in it's just the rash, it's one thing. But if it's rash and fever, okay, now we may look at it a little bit differently. So
Yeah.
that's one that would worry us. So we had petechiae or hemorrhagic rashes, the non-blanching rashes that we talked about. and we talked about vesicles
So
as two examples of rashes that could be of concern and do warrant a touch base with a doctor probably or a healthcare professional.
the blistering rashes and the petechiae blanching rashes, and then any rash where you feel like your child is not well. So not eating, not drinking, not peeing, not acting normally, all of those kinds of things. And other than that, I mean, I think that for me, the list of rashes where you're really sick and really worried are quite narrow. But the other one that I kind of always am like, just let me know about is whole body rashes, because it's kind of unusual for a rash really to be an entire whole body rash, unless there's something else kind of accompanying it. And so those I want to know about. And I guess just to go back to the vesicular rashes, the other one that's quite common with blistery rashes are children who have underlying eczema can get bacterial infection. So anything that's blistery or crusting, kind of weeping, all of those rashes, you kind of want to touch base with your doctor about, because they are something that potentially would need treatment, even if it's something, that seems kind of very simple, like topical antibiotics. You just want to reach out and let us know.
Ah, the crusty rashes.
Right.
Well,
And
that's a
whole body rashes.
whole body rashes. Well, crusty also. I mean, the probably a very common one. Probably the audience probably should just know about is impetigo, which is probably the mother of all the crusty rashes, and it's described as honey golden crust. When I said in the beginning when we were talking about rashes that have these catchphrases to them, so herpes, for example, is grouped vesicles on an erythematous base. Okay, translate to English. That means vesicles, these little tiny blisters, but not isolated, spread out, separate, but kind of a bunch of them. And the area right around the little bubble is red. Chickenpox has a classic description. It's also a vesicular rash at certain phases of it. And it's described as a dewdrop on a rose petal
Right.
kind of description. So it's like a little blister with a little bit of red, but again, not grouped the way herpes typically is. So we have all these kind of very romantically described or interestingly described catchphrases that try to imprint in our minds as healthcare providers what certain rashes look like.
Yeah, and impetigo is definitely a big one. And the reason I think, again, you should just A, because you should treat it and you can treat it. And B, it can spread depending on the child and what they're underlying, especially if they have underlying eczema that's kind of diffuse. Those kids, as Dr. Kassuto was kind of alluding to, eczema, when we don't mean breaks in the skin, we don't mean you're missing a large chunk of skin, but when you have eczema, you do have little micro breaks in your skin, and those are areas where bacteria can get in. And interestingly, there was just a really, I think it was in JAMA, but correct me if I'm wrong, article talking about eczema and how to reduce complications of eczema, treatment for eczema and bacteria getting into the skin. And when I started off, the teaching was kind of not to overly bathe children with eczema because it would dry out their skin. But they just did this really large study that kind of refuted that and said that children who are bathed frequently and moisturized frequently actually have less complications from their eczema because their skin is probably cleaner, and because they have those micro breaks where bacteria can get in. So frequent bathing with frequent moisturizing is actually the best way to go.
Part of the goal of eczema treatment is to reduce the scratching. In general, any of the itchy rashes, you really you want to try to reduce how much your kid will scratch. And you're talking about those micro abrasions. It means like even just scratching a little bit hard. The skin generally does like this amazing job of keeping all the germs out of itself. I mean, the skin is covered with germs. We're all covered in germs. They've done all these studies and healthcare workers. That's why the hand hygiene is so important. It's all over us. Parents are worried about MRSA as it's a Staph aureus. It's a germ that causes skin infections. A lot of people are walking around with this stuff on your skin. It becomes a problem if you break your skin. So if you're scratching, it doesn't even have to be a cut. And of course, kids who have these scaly skin conditions, such as eczema, their skin is already has these areas that bacteria can get in. And on most days, amazingly, the body manages to keep it under control. So sometimes it depends on the kind of germ that happens to be there and how much of that germ is there, or how much of the skin is quote unquote broken, as in the barrier is the defenses are even less robust than they can be because of all the places it can get in. Then they settle in and cause problems. So we do see the impetigo as an example very, very commonly on top of eczema, and also where the germ happens to be. So impetigo, the classic distribution is kind of nose, upper lip, around the mouth, because a lot of times the germ lives in our noses. Our kids, it's just there. And we've got, everyone knows about now the biome. There's germs inside of us and outside of us, and sometimes they're just there, sometimes they're helpful to us, and sometimes they're harmful to us.
Yeah, so I think that kind of is a nice, what to primer for parents. I think eczema being the most common, keep your child washed and bathed and moisturized. Call your pediatrician, definitely if your child is sick. Definitely if you have a rash that you press on and it's not going away. Or if you have any of these blistery rashes or whole body rashes. And we could spend another hour, I think, talking about whole body rashes.
And viral rashes, we didn't even get into that. Viruses that are very common cause of rashes in children.
Right. Actually, you know what? We should probably touch on it just briefly, because now that you're saying it, that is another one that I think often winds up in the emergency room because it is a whole body rash and looks scary, right, but is not a necessarily, emergency scary rash.
But your touch base is a good example, is a good recommendation, I think.
Right.
It doesn't necessarily mean you have to come running to an ER, but many viruses can cause actually a variety of rashes. We mentioned hand, foot, and mouth, which can be not just hand, foot, and mouth, but it could be more spread out. We talk about generic viral rash, right, and it's doesn't specify what the virus is because lots of viruses can do it. There are other general rashes. Most of them, they're drug eruptions that are whole body. So medications are common. Infections are common causes of rashes. Medications, and sometimes even chemical exposures or things that the skin has been exposed to can cause rashes that are more than in just one area.
Right.
And that is like while standing on one foot. There's a lot to go in there. People write textbooks about this stuff. So obviously there's a lot.
Exactly. I mean, those are kind of like the broad ones I say definitely call me about, and then I always put in the caveat, or if you're concerned, of course, definitely reach out, because there are a lot of different reasons that there can be cause rash. A lot of these rashes are itchy or bothersome to children, and we want to do the minimally invasive thing, the least harmful thing to keep them from scratching their skin so that they don't cause those little micro abrasions, because those can become risks for infection. So I think that's a pretty good reasons to call your doc. They don't go away. They look like blisters. They're whole body. Your child seems unwell, or you have any kind of concerns. Definitely, just at least that warrants a phone call to your doc.
And non-blanching on that list, yeah.
And then hopefully, your doctor can help you decide whether you need to go in and see someone like Dr. Kassuto if it's a real true emergency. You can kind of navigate that together and figure out where the next best steps are.
Yeah, but general pediatricians get quite good with rashes because, again, it's really a day-to-day from the doctor's perspective. You guys see a lot of it. I know my wife does as well. So,
right. I think usually if you do reach out to your general pediatrician, they actually hopefully can help, save you a trip to the emergency room. Usually the children who wind up in the emergency room with non-emergency rashes, it looked really scary and they didn't have a chance to reach out to their doctor yet.
Right. And some of these rashes that aren't harmful can look very scary. So that's the other. It's sometimes hard for a parent to tell. It's like, oh my gosh, and it's okay.
Right.
but I wouldn't expect a parent necessarily to know that. And so that's where reaching out is important.
Exactly. All right. Well, thanks so much for taking the time out of your day to talk to us about rashes. Hopefully this was helpful. And if anybody has any questions or comments, of course, always leave them at the end where I'll get back to you.
All right. It was good to talk.
Thank you for watching The Beehive Doc Talks with Dr. Blair Rolnick. For more episodes and her practice, visit BeKindPediatrics.com and don't forget to subscribe for more parenting tips wherever you get your podcasts. This information is for educational purposes only. It is not medical advice. Always seek medical advice from a qualified physician.